I would like to now start the technical part of the program, and it is my pleasure to welcome a colleague, Professor Nigel Goldenfeld. Nigel holds the Swanlin Endowed Chair and is the Center for Advanced Study Professor in Physics at the University of Illinois at Urbana-Champaign. He is also the director of the NASA Astrobiology Institute for Universal Biology at UIUC and leads the Biocomplexity Group at also our university's Institute for Genomic Biology. Nigel received his PhD from the University of Cambridge in 1982, and from 1982 to 1985, he was a postdoctoral fellow at the Institute for Theoretical Physics at UC Santa Barbara. So from the description, and you might think that Nigel is a theoretical physicist, and you'd be right, but he's also somewhat of a polymath, and he does many, many things. It's very impressive that in 1996, Nigel co-founded Numerics. It's a company that specializes in high-performance software for the derivatives market. He serves on the editorial boards of several journals, including the Philosophical Transactions of the Royal Society and Physical Biology. Has won many, many honors, including the Alfred Sloan Foundation Fellowship, the Xerox Award from the University of Illinois, the Nordseek Award for Excellence in Graduate Teaching, and the American Physical Society's Leo Kadenoff Prize. Nigel is a fellow of the American Physical Society, a fellow of the American Academy of Arts and Sciences, and is a member of the prestigious U.S. Academy, National Academy of Sciences. As I mentioned, Nigel works on many, many things, and even though he's officially a physicist, today's talk will be on his remarkable contributions to helping the University of Illinois decide how and when to open up and our university in the middle of this COVID crisis. And Nigel was one of the people who led the modeling side of what would happen in the event that the university opened up. So without further ado, I'd like to turn it over to Nigel. Go ahead, Nigel.
Thank you very much, and thank you very much for inviting me to give this talk. So I'm very happy to be here, and look forward to hearing your questions after or even during, if necessary, my talk. So I'm going to focus mostly on modeling, and these are the people who I work with. I'm going to give you a little bit of the history of this. Our team is basically Ahmed Albana at Civil Engineering, who is a civil engineer with also some sort of physics mechanics background. Sergei Maslov, who's a physicist and is in the professor in bioengineering and in physics, and also the Institute for Genomic Biology. And then we have a group of absolutely fantastic, hardworking graduate students in physics who are volunteering their time. In fact, we're all volunteers. None of us are being paid to do this. Zach Weiner, who is a cosmologist, George Wong, who works on the Event Horizon Telescope, and you've seen many of his images and work in publications and in newspapers. Hantao Zhang, who was an undergraduate, worked with us. Alexei Tkachenko at Brookhaven National Lab, and my former undergraduate student Jiru Liu, who's now at Stanford. So SHELD is what we call the scheme that we set up at the University of Illinois. It's our COVID response system, an ecosystem, as we like to call it. And this is today's dashboard, showing you in blue the number of cases over day, in yellow showing you that day's case positivity. You can see that we've done over 1 million tests at the University of Illinois in the last semester. We sometimes do 1% of the daily tests done in the United States. And I'm leading the modeling here, but I want to give a shout out to literally about 100 other people at the University of Illinois campus who have contributed meaningfully to this and really worked hard to make this happen. Marty Burke, who is the project leader, Rebecca Smith, who is the epidemiologist on the group. I work very closely with her. Paul Hergenrother, who with others devised the unique test that I will tell you about that we are using. Tim Fan and Rick Fredrickson, who run the veterinary diagnostics lab where we do all our testing, and many others, but on the side of the university administration, student engagement, student participation, and so on and so forth. It's a huge list, and I can't really give all the names here. So what I'm going to talk about is, I'm going to start off by just saying a little bit of prehistory, COVID-19 in the state of Illinois. Then I'll talk about how we did set up SHELD surveillance testing of an entire university. I'm going to talk about our agent-based modeling and what's unique about our modeling compared to other models that have been produced for college or school reopenings, is that ours is based on the physics of aerosol transmission dynamics. We realized early on that aerosols are the main factor, primarily by looking at super spreading statistics. I will review what we saw in fall 2020 and give you some outlook for what we see coming ahead, and also talk about the impact of the B.1.1.7 variant. So I want to give a couple of disclaimers. The first thing is that the purpose of modeling is to understand the past and predict the future trends semi-quantitatively. Trends are more robust than precise numbers and can be used to plan responses. We do not expect to be able to predict numbers. I will show you numbers that we calculate here, but those numbers are sensitive to assumptions and things like this. We understand that. What's important really are the take-home messages and trends that we see in our models. So when we predict a number, it's not that we're expecting on a particular date to see exactly this number of cases or even anything directionally like that. And I will explain that in more detail later. In addition to this, epidemic modeling is hard because behavior is fundamentally unpredictable, and that can change as a result of the modeling. We can predict that everything is going to be fine, that SHELD will work during the semester, and we don't have to worry about transmission at the University of Illinois campus. As a result, everybody goes out and parties so much more, and that can then change the predictions. And it can work the other way around too. We can tell people things are going to be bad, and then people will hunker down in their basements, and so that will change the outcome. So the predictions or the modeling can actually change the outcome and falsify. So, and that's important because in 2015 we were identified as the #1 party school in the United States by Princeton Review. I guess Princeton has the expertise to make that assessment. So, and that, as you'll see, was a significant challenge for us. Okay, so cast your mind back about 10 months or so to March and April 2020, when testing was inadequate to track COVID-19 in Illinois, and the only way we could see the disease was through mathematics. And even though the number of reported cases in Illinois was only about 100, we could predict the dramatic effect of a preemptive stay-at-home order, and we modeled that, and in fact communicated our modeling to the governor's office, and was part of the considerations that went into the state's decision to have a lockdown around about March the 20th, along with California and several other states, and actually before even New York. So here you can see some of the early data. In March the 11th, we had about 20 cases confirmed in Illinois. A week later, we had 100. The doubling time was about 2 days, 2.5 days, something like this. This was an exponential on a straight line on a semi-log plot. And of course that panned out. So this is what I was just showing you. Now we expand the scale, and you can see that again we had exponential growth followed by tapering off with 100,000 plus cases already by May in Illinois. So what we did was we did a calculation which you can read about on medRxiv. It's over here. And basically what we did was we looked at the impact of 2 possible mitigation scenarios for Chicago, but implemented at different times. So to try to make this an apples to apples comparison, we looked at what happens if you have some sort of mitigation which can lower the reproduction number to something like 0.9. And we looked at what would happen if we did that by April the 1st or waited a couple of weeks. And the reason we were thinking about these things is because we could see what was happening in Italy, we could see what was happening in New York. And so it was clear that at that point, the only tools that we had were blunt tools for mitigation, and these were the only options on the table. And you can see that the earlier the mitigation is done, you go under this dashed line here, where if you wait a couple of weeks, you overshoot. Now, what this dashed line here is the capacity of the healthcare system in Chicago for ICU beds. And so what we were suggesting was that early mitigation would prevent hospital overflow, and indeed, that is exactly what happened. After that, the state of Illinois set up a modeling group. Right now, there's us, University of Chicago, Northwestern University, and Argonne National Lab. We work with a data analytics company that does data federation for us from sources, including the Illinois Department of Public Health and elsewhere. We make weekly reports together to the governor's office. And the reason that we think it's important to have this wide range of models is that there's no time for peer review. And so what we look for is common trends and consensus in the modeling. And even though the models differ in the way that they're set up, they're completely independent, we are able to achieve a good second, third, and fourth opinions on the predictions that we and others are making. So this has been quite a remarkable collaboration, and we predict a number of things for the state. We're primarily interested in preventing the exponential growth of the epidemic and overflowing the ICU capacity. As we all know, it's very misleading when you have exponential growth. You can have a doubling time of 2.5 days. So on Sunday, the ICU may be half empty. The hospital thinks it's fine. By Wednesday, it's full. And by Saturday, doctors are treating sick patients in the car park because there's no room in the hospital. And that was our primary goal in trying to start working on COVID modeling. Fast forward to what we're doing right now for the state. What we do is we adapt a metric that we first used in financial modeling. So those of you who've had some background in finance may know about value at risk, which was a Monte Carlo sampling scenario technique that was developed in the middle 1990s, and to try to estimate what is the chance that you will lose more money than you would be comfortable with in a given time period. And so what we do, in fact, is we do simulations forward in time, and what we try to see is what fraction of the future scenarios will exceed the hospital capacity, and in this way we can make predictions for the state about what is the probability that any particular hospital system is going to be overwhelmed, and if so, give the state a few weeks advance notice so that they can set up alternatives. So that's one of the things that we do. That kind of modeling is published. We use a non-Markovian age of infection model. We use Markov chain Monte Carlo methods. If you're interested, you can read about it here. Now, as we know, to beat exponentials, we have to reduce the reproduction number below 1, and the strategies for doing this have been known for centuries. Isolate infected people, quarantine people who may have been close contacts, practice good hygiene and social distancing, and for airborne diseases, wear masks. And if necessary, lock down populations to get the cases down to a manageable number. So that was the background for which we started SHELD, Target, Test and Tell, which I'm going to tell you about now for the rest of the talk. And we call it Target, Test and Tell because there's really 3 ingredients to it. The centerpiece is probably a unique saliva-based test that we developed here. And I'll tell you why we developed it and what's special about it. But for now, let me just say that it's cheap, it's non-intrusive, it has a fast turnaround, it's accurate and scalable. And what's an important feature is this: if you're going to mitigate an epidemic, you want to do surveillance testing, because we know that there's a large fraction of asymptomatic and pre-symptomatic transmission for COVID-19. So just testing people when they have symptoms is not going to cut transmission. So that means you have to test the entire population. And in fact, one of the things that I will show you is that we discovered that if you only test them once a week, it's not enough to prevent transmission and to prevent exponential growth. You have to do it more frequently than that. So now you've got a situation where you're going to ask 50,000 people to test twice a week, and obviously trying to do a nasopharyngeal test or even just a throat swab or something is not going to be, is intrusive enough that you would expect people not to be really too happy about having to do that. Plus, you have to worry about things like PPE and qualified staff. So we developed a different test. Then we set up a data analytics team, which I'm part of and lead with Becky Smith, the target team, which tries to understand how we can prioritize testing based on risk assessment and try to improve the overall effectiveness of SHELD mitigation. And then lastly, we partner with the Champaign-Urbana Public Health District, and they're the people who do the thing that actually prevents transmission. What SHELD does in terms of its testing, it's like taking the temperature of a sick patient. But until you actually give them the aspirin, they're not going to get better. So what Champaign-Urbana Public Health District does is it is in charge of contact tracing, case investigation, isolation and quarantine of the cases. And we also work in partnership with one of the local healthcare providers as well. Another part of what we do is we developed a unique app called the Safer in Illinois app that has many functions, including receiving the results of your COVID tests, as well as providing building access. I will get into that just in a little bit. So let me tell you what the goal of SHELD is. So the goal of SHELD is essentially to prevent exponential growth of transmission on campus, to keep the number of cases to a manageable level, and to be able to keep the campus open so that we can have some simulacrum of our regular academic and social activities. So let me give you a quick walkthrough of how SHELD works. So the first step is SHELD set up these tents, with about 20 tents around campus. Now we've moved indoors because it's winter, and we do saliva collection. Literally, an individual arrives, checks in with their ID. That is all connected to databases. We print out a little a docket that is put on a collection tube to identify the patient or the individual. The individual provides a specimen by literally drooling into a test tube, places that on the collection rack, and that time takes about 2 or 3 minutes. Then what happens is those racks are taken by golf carts to the veterinary diagnostic laboratory, where they are subject to RT-qPCR, and I'll tell you a bit more about that in a minute. And we are able, in some cases, to get results back within 6 hours of sample collection. Our median time for positive results returned is about 12 hours. And the patient gets notified by the physician, and also to the Champaign-Urbana Public Health District and the state's system. So that's what we do, and we repeat this twice a week for everyone in the university. That means that we are doing essentially 10,000 tests per day. So what's special about our test? So the usual method is, as everybody knows, is a swab. Then you use viral transport media then to RNA purification, and then finally PCR. So what we do, we cut out the middle steps here. We go straight from saliva collection to PCR. And the way we can do that is through some miraculous chemistry that Paul Hergenrother's team developed, where they discovered that we don't really need to do RNA purification. They discovered a heat treatment and an enzyme treatment that leaves out these steps. And that's important because it makes it faster, it makes it safer in terms of what the lab personnel have to wear in terms of PPE. It means that it's cheaper. It also means that we cut out supply chain bottlenecks. So we're not using the same reagents that everybody else is doing. And so we do these tests very fast, and we cut out these intermediate steps, and that also makes things cheaper. And so anyway, so it's a very unique test, and it's been taken up by many other institutions. Here's a picture of our our diagnostics facility. I'm not going to go through this in detail. And we have a lot of testing locations, sample collection locations around campus in order that we can make it easy for people to be compliant. So what we have to do to make this successful, it's also about behavior. So we have to partner with our students and try to work with them in order to encourage safe behaviors. And we also partner with our public health district. So as I said before, the saliva test which is what gets the newspapers a lot, is really only the beginning. We have to break the chain of transmission. And so we chose to partner with the health district in order that we had the ability to legally enforce mitigation measures and have a trusted source. So somebody's microphone is open. Would you be kind enough to mute it, please? Because I can hear distracting noises. I think it's Magnus K. If that's you, please could you mute? Thank you. Okay, so as I said, it's all about behavior. And so that's one of the things that we were not so good at initially, because the team was set up mostly with physical scientists and chemists and epidemiologists and so on. So, but we have understood this and right from the beginning tried to build these things in. We try to educate the students while we're asking them to comply with our requirements. We engage with the students and partner with them. We have student ambassadors who work with their peers in terms of encouraging compliance and helping them when they get isolated. A lot of things that I don't have time to go into. Empowerment, we have a sort of do-to-do model. We have carrots and sticks. We want there to be more carrots than sticks. The reason that we want people to do our test and to be compliant with our requirements is so that they can get building access, and in fact not just building access to our university, but even some of the local bars and restaurants use our app in order to do that. Sometimes things don't work out. We have to have a fairly rigorous enforcement process because we have had a lot of compliance issues, particularly at the beginning of the semester. So what the target team tried to answer was the following: who do we test? When do we test them? How often do we test them? What other mitigation strategies can be effective? And can we reopen the campus in a hybrid way safely? Or is this a moonshot that is doomed to failure? So the brief answers, which I'm going to go through now in a minute, are that we test everybody. We test people on arrival on campus, so that's entry screening, and we're just doing that right now for this coming semester. And then we test people regularly throughout the semester. And in fact, you will see that initially we found that SHELD would not work. We were testing too infrequently. So we'd have to test twice a week. Some people who are at low risk, we only test once a week. That's typically faculty and graduate students. And some people who are at high risk, we test 3 times a week or every other day. And those are the most socially active students. And then what our modeling suggests is that there's a nonlinear interaction, a nonlinear combination of all the non-pharmaceutical interventions that we provide a manageable epidemic. So we do frequent testing, we do contact tracing, isolation, we have universal masks on campus, we restrict class size, we use app-based exposure notification, and all of those things bring it down to a level where the epidemic does not grow exponentially. So here's a high-level description of our agent-based model. So this is different from the model that we use for the state. So what is a university? It's a place where students and faculty come together at specific times and places for classes and also, of course, social life. So we have 45,000 agents in our model. That's how many students are in the university system, plus staff and faculty. We have a variety of zones: classrooms, bars, restaurants, dorms, coffee shops, libraries, other gathering places. And as a data input, what we did was we constructed the anonymized social network of all the students and classes for the university students. So this is the usual hairball diagram for a social network. The nodes are classes, the edges are students. And what we find here is that the network of the classes makes up a small world network with about 2.5 degrees of separation. So that means that that students cluster by common classes such as required classes or by major. And because it's such a small world network, it means it's the ideal situation for COVID-19 to spread rapidly. Now we also do physical modeling. So we realized very early on, long before the World Health Organization realized this, that COVID-19 is primarily spread by aerosols. It's very hard to really understand the overdispersion and other case histories if it's just from droplets that fall to the ground within 6 feet or fomites. So in this cartoon here from Morawska et al.'s article, you can see somebody in a room producing a quanta of aerosols that contain viral particles. We know now that they stay airborne much longer than just falling to the ground within 6 feet. The whole 6 feet thing is simply outdated. We know that COVID-19 can be spread by people with no symptoms. And we know that 10% of the cases contribute to 80% of the transmission. So any modeling has to really reflect all of those things. So what we build into our models is we literally follow stochastically students as they go through these different zones. We include parties. We have 7,000 students, which is the size of our Greek community, in parties 3 nights a week. Actually, we now increase this to every night a week. We model the physics of aerosol spread and virus infection in different locations. And the reason for that is we know from studies that essentially, if you're talking, you're emitting a certain number of quanta. If you're wearing a mask, you emit much less. If you're shouting, say in a crowded bar with loud music playing and no masks, you produce even more quanta. And those things have been quantified. We know those very well. And so we put all of those as input into our simulations. And I particularly want to talk about, shout out the work of Jose Jimne at the University of Colorado, who's done a fantastic public service in publicizing the role of aerosols and providing a lot of incredibly useful data to the scientific community. So what we do is we calculate how many students are going to show up on entry screening. This is an example of what happened, what we predicted at the beginning of the fall semester. We predicted that there would be some bump of about 200 plus or minus 100 cases as students return. In fact, we actually did the calculation 3 different ways, and in fact the results were that we had exactly that. We had 288 cases detected in entry screening, 367 cases by the following day. Now, these are numbers that if you'll cast your mind back to August, you will think these are pretty high numbers of cases for a university to report. Most universities around that time, when they started to find any cases, immediately shut down because they did not have plans in place for mitigating COVID-19. They were just seeing the tip of the iceberg. You know, somebody was feeling really sick and they went and got tested. Because we're testing asymptomatic and pre-symptomatic people, we see the entire iceberg. And so we were not, we were expecting this, and this was, you know, exactly what we wanted to, you know, we were expecting. Now, let me just very quickly just show you, we examined what would happen if you did testing every week. And I'm not going to go through this in detail. The numbers here are illustrative, okay? There's many different factors that come into them, but I want you to notice the trends. If you have the number of people here, you look at how many agents get infected overall during a semester, you find that if you do nothing, you'll get the whole university infected. If you do seven-day testing, ultimately about 35,000 agents would get infected. You go down to a three-day cycle, and now that number has gone down to about 11,000. That's without doing anything else, just testing. But we do many other things as well. We do contact tracing. One of the things that we discovered from simulation early on was that because of the high transmission of COVID-19, we discovered that if you don't get the contact tracing done within about a day of infection, it'll essentially be useless in terms of reducing transmission. So it's an absolute race against time, and we were not the only group to understand this. And so people realize that you have to do get test results back fast, and start contact tracing, case investigation and contact tracing really fast too. So another thing that we did, I'm not going to go spend so much time on this, is a digital exposure notification. So we can use low energy Bluetooth to do proximity detection, and there's been a lot of apps that do this around the world. The most important thing I want to mention is that two things. One is that most exposure notification apps, so what they do is they will tell you, they're usually following a privacy preserving protocol, which I'm not going to go into, but what they usually tell you is that you are close to somebody who subsequently tested positive, and then you should quarantine and get tested. Now those things work by everybody being on using Bluetooth, and so it requires that the app has a very high adoption rate. So most apps that have been tried throughout the world have had a very low adoption rate of maybe 18 or 20%. When you simulate this, you find that the adoption rate needs to be about 60 or 70% in order to have any chance to reduce transmission. I think I have that over here. I'm not going to go through this complicated diagram for you. What we did was we built into our app a lot of convenience features. And so our app actually has a huge adoption rate. Essentially, everybody on campus is using our app for either access to building or to receive in an easy way the results of their COVID tests. So we also used modeling to improve the sensitivity, the effectiveness of the app. So here's a phase diagram of positivity, the probability that if you get notified and get tested, it will be positive, versus effectiveness. What are the fraction of new cases actually identified before testing? And so there's sort of two regimes here. In this regime here, you set the parameters in your app so that if you think there's a likelihood that you were near somebody who wasn't infected, you get an exposure notification. So that means that everybody who could be infected is contacted, even though they actually have only a small probability of being contacted. So you will detect every new infection, but you'll also have a huge number of false positives, and then people will stop using the app. So what we did was we tuned our app using modeling parameters, using parameters that we deduced from modeling, so that everyone who was contacted has a much higher probability of actually being infected, and that's how we've used our app on campus. So the way that SHELD works, it's a multi-layer approach. The way I like to present its effectiveness is in terms of the reproduction number, which tells you the average number of people that you will infect if you are infected. And the higher this number is, the worse it is. If it's below 1, the epidemic will eventually decay. The lower it is, the faster it will decay. And what our modeling showed was that if you have no mitigation, the reproduction number will be about 3.2. If you just do 2 tests a week with nothing else, that on its own will reduce transmission by 1/2, but not enough to make it safe. If you wear masks, it reduces the transmission, but not enough to make it safe. If you put the two things together, it now produces already a very good outcome, namely you're well below 1, and so you'll have the ability to control the epidemic. Classes online, meaning partially online classes bigger than 50 students have to be online. That has some mitigation effect. When you put that together with these other things, you get a reproduction number that can go down as low as 0.3 or something like this. We never achieve that in practice because of lack of compliance, but in principle, it shows you that this multi-layer approach can work. So we can also use we can also use, I don't know if that was a question or just an interruption. We can also use modeling to tell us where the infections are going to happen and which are the most dangerous locations. So if you have no mitigation, the classroom obviously is the most dangerous place. Poorly ventilated, people are close together and packed in. You can get many infections that way. If you, and these are for 2 different models that we used, if you now put in these various non-pharmaceutical interventions, now the scale of numbers goes down by orders of magnitude. So what else do we learn from modeling? Well, what we learn is that the time scale of decay of the epidemic, once you have a peak, such as an entry peak, is about four weeks, and that turned out to be true in the data. And so we can also look at the effects of non-compliance and test processing time. And so we were prepared for those things when the semester started. Okay, so let me show you what we've seen. So I'm going to use a statistic, case positivity, as a sort of single number, which is a loose figure of merit. It's not perfect by any means, but it does tell you an interesting thing. So what case positivity is the number of new daily cases over the number of unique individuals that you test. Well, what's written here on the slide is wrong. So what that means is, how many people do you need to, if you invert this, what it tells you is how many tests or unique individuals do you need to do in order to find a new infected person. So if your positivity is 1%, that means you need to do 100 tests to find a new infected person on campus. So that's really good. If it's 25%, as it was at some of the other universities in Illinois when they had their entry spike, you need to do only 4 tests to find a new infected person. And that says that the epidemic is fairly widespread on campus. So here's some of our testing data. Here are the students coming back to campus. Here on August the 31st, we had a spike of 200 cases. That spike went down. You can see our positivity was fairly quickly less than 0.5%. That was on September the 10th. By October the 19th, what we'd seen was the epidemic die out. It took about a month time scale to decay. We were at a much lower positivity than our town or the region or the state. Going further into the semester, what you saw happening was our cases go down. At this point, we were down into single digits for a week or so. At this point, after the end of October, we had start of football, we had the Thanksgiving, we had the election, and so cases were rising in the region. We had a lot of parties on campus, and so the cases went up and the positivity went up as well. And by the end of class, we were back down to here. So what SHELD did was prevent exponential growth of cases, even with multiple drivers of outbreaks from parties and the exponentially rising background of cases in the region. We had no serious illness and no hospitalization, thank goodness, and also no spread to the community. The university stayed open, and many activities were facilitated that could not happen with remote learning. So after Thanksgiving, we saw a spike, and we also saw a spike after the Christmas and New Year break. Here is a comparison of what happened in our surrounding region. So these are the cases in the University of Illinois. This is a log scale. This is just a linear scale. What happened was the cases in late November were rising exponentially in the Midwest and in our region of Illinois too, but they stayed bounded at the University of Illinois. So I want to skip some of these slides here. I've got lots and lots of data that I can show you, and I can be happy to answer questions about that. One of the things that we were concerned about was the spread of COVID-19 in the town. So we wanted to know, is there a spread from students to the community, as people were worried? Is there a spread of COVID-19 from the students to the staff and faculty? And is there a spread of COVID-19 from the community to the UIUC or vice versa? So we looked at several measures. We looked at correlations. We looked at correlations between cases amongst staff and cases in Champaign County, and you can see that there is a correlation here. What happens here as time increases, you're going up like this, and then later the number of cases drops for faculty and staff, but goes up in the community. We also checked that with no correlations between undergraduates and staff, and also between undergraduates in Champaign County. So we wanted to understand, we saw there was a correlation, we wanted to understand causality. So what we did was we used a transfer entropy for the time series we had computed, we had taken to compute the causal connection. And so what we saw very strongly was a direct causal relation between what was happening in the state and what was happening in our community. Basically, our staff were being infected by the rising number of cases in the community, not the other way around. And there was very weak correlation between anything that was happening amongst the students and anything happening between them and the staff and them and the community. And what we deduced statistically was consistent with what our contact tracers found when they did case investigation. So we were happy about that. Some of the drivers of cases at the university, well, one of the things that we were worried about was testing delays. If you take too long to test, is that going to drive cases? And the second question is, are parties and social activities influencing the cases? So what we looked at was the test turnaround time over the semester. We monitor that, and we look at that for the negative cases and the positive cases separately. And the reason we do that is when we get a positive case, we want to reduce any false positives. So what we do is we double test people who show up positive. And so that takes a little bit longer. And so when we plotted the test turnaround time versus the cases, so the cases are in orange, the turnaround time is in blue for the positives, what you see happening is that the largest spike in turnaround time occurred after the largest spike in cases. So in other words, there was no causality between test turnaround time and spike in cases. And that was also true for less dramatic events later in the semester. So here I'm showing you the 7-day averaged daily positive cases and test turnaround time. And you can say that even though these were going up and down, there was no, it was not being driven by the turnaround times. So what was it being driven by? Well, it was being driven by social activity, and we had a way to test that. What we did was we looked for parties, and we know how many parties there are because we can track how many disturbance and non-compliance calls the police get. So what we discovered was that if I look at the number of police calls and the number of cases in the same week, there's some correlation, but it's fairly weak. But it becomes a much stronger one if you look at the correlation between police calls and cases in the following week. And the reason for that is Thursday night is the big party night on campus, and those cases, then there's like a 4-day delay before you become test positive. And so Monday and Tuesday is when we start to detect the previous week's cases. All right, and then lastly, I'm going to end in just a second and take questions. We looked at the attack rates by different residences, and we saw that those attack rates highly correlate with propensity for socialization, as we had many different ways to quantify that. Okay, so I think I'm going to jump to my conclusions. I'm not going to go through B117, but I'll be happy to talk about that later on. So basically my message is that surveillance testing of 50,000 people is doable. You do freak, regular, non-invasive RT-PCR tests. It's adaptive. We adapt the test frequency in space to focus on locations where we see outbreaks, and also in time for groups, demographic or stratified groups that are showing a higher risk. It's a race against time, but it's one that you can win. It's essential to partner with public health authorities, and the outcome is that even during a pandemic, growth can be prevented, and you can prevent exponential spread. And we think of this as a kind of pilot case for what communities in the US and elsewhere could do. And we are in discussion with many other organizations, both states, universities, private companies, even countries, in terms of replicating some of the things that I've shown you in their situations. So with that, I will conclude. I'll be happy to take questions. Thank you very much for your attention.
Thank you, Nigel. That was a wonderful talk, and congratulations to you and the SHELD team for keeping the university safe for our students. We have a couple of minutes for questions. There is one question on chat. Eric Mealing. Eric, do you want to unmute yourself and ask your question?
Sure, thank you. So first, very nice talk. Thank you very much. So my question relates to the exposure notification system, and I'm wondering if this can lead to a false sense of security in that someone who doesn't get an alert may feel more confident that they're not infected and go and socialize more.
That's right.
How might this be mitigated?
Yeah, I think you're right about that. We are less worried about that than we are about the false positives, because we want people to if they get an exposure notification to be to respond to it. So the reason we're not worried about what you asked about is that because we test everybody twice or 3 times a week, if we don't catch you right after the exposure notification, we will catch you the next time. So it's not perfect, but it means that that nobody is going around for a long period of time and not and causing transmission. So so we tuned the exposure notification app so that it basically only if you're within close proximity to somebody for a long period of time, so we're really sure that you had a really high likelihood of being exposed to a high number of quanta, then will you get a notification. So in practice, the exposure notification app is one of the is up to now we have used it as a very weak mitigation strategy. And the reason is because also with exposure notification, we have no way to tell if people are being compliant. It suggests that you should quarantine, but it can't be enforced. And because it's a privacy preserving app, we don't know who those people are, and so we can't even enforce it or monitor it. So we're not, in practice, we're not too worried about that. There's much greater sources of transmission than that is. So I hope that answers your question.
Yes, thank you.
We have 1 more minute before the next talk. Is there a quick question from Shankar?
Shrikant, this is Shankar. I'd love to, you skipped over the slides on the B117. I wish you could tell us just a little bit about what you think the impacts of the 117 would be.
Yeah, I think the impact of B117 is going to be quite terrible. So for those of you who don't know, B117 is a new variant that was identified by genotyping over the Christmas holidays in the UK. It's 50% more transmittable than the regular strain. And so what we've studied is what effect that would make on our total number of infections in a computer simulation. And what we discovered something pretty interesting, which is that I'm not going to go through this in detail, but basically, if you increase the level of compliance, that is more effective in reducing the total number of cases when you have a high transmitting virus than if you increase the testing frequency. So these are data for the regular strain where you have 60% compliance, which is what we think we had last semester with 2 tests a week. We had about 4,000 cases since the start of our testing on campus. If you increase the compliance, that would have gone down to about 2,500. With B117, that 2 tests a week and 60% compliance, you would have close to 6,000 cases. But on the other hand, if you increase the compliance level but keep 2 tests a week, you can see that you reduce that by a huge amount. So we get a definite signal there of what we should be doing in order to deal with the B117 situation.
Fantastic. This is consistent with that. There was that German study, I guess Regensburg, which had only for masks, there was a compliance, a 78% compliance rate was what they needed to. This of course early, so it was from August, so maybe it's somewhat old data. But I think these compliance numbers are fantastic, just fantastic.
Yeah, so compliance is the biggest issue for us. We even got into the newspapers and XKCD when people you know, we modeled lack of compliance. We knew that that would happen. We knew that people would be partying. We knew they wouldn't be wearing masks and all that kind of thing. What we didn't anticipate was that students would break a law. We didn't expect that even if they knew they were COVID positive, that they would still be going around. We didn't expect them that they would still go to parties. We didn't expect that they would still hold parties. All of those things were things that were surprising to us. In fact, no other modeler I know of anticipated those things and included those things in their modeling, but we do now.
Fantastic.
Thank you, Nigel. That was a wonderful talk.
Great talk.
Yeah, great start to the workshop. I'll now turn it over to Larry and Jane, Camille to continue with the rest of the program. Thank you.